Good morning and welcome back, students. We will continue our topic of enzymes. Today's competency is competency number 2.7, in which the subtopic is interpretation of the levels of serum enzymes in various diseases. Blood contains two types of enzymes: functional enzymes like coagulation factors and non-functional enzymes. Non-functional enzymes means the enzymes which have no role in the blood, but they have functions in various tissues and cells. These enzymes are synthesized by various cells of the tissues. They perform their function inside the cell and they enter into the blood during normal wear and tear mechanism. Hence, the level of these enzymes in the blood is very low, and these enzymes are very specific for the tissues. For example, a tissue A synthesizes enzyme B, and tissue D which synthesizes enzyme E. Therefore, when we measure the concentration of enzyme or enzyme activity in the blood, and if a enzyme B level is found to be increased in the blood, then we can diagnose the disease of tissue A. So in this way, the enzymes are very specific in the tissues. Second thing, when these tissues are damaged, all the enzymes present inside the cell enters into the blood and their level in the blood increases. And this is seen mainly during cell death or necrosis, cancers of cells or tissues, inflammations and infections of the particular cells. First, we will study the enzyme profile in liver and biliary tract disease. Here we are studying the following enzymes: alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, nucleotide phosphatase and gamma glutamyl transferase. These enzymes are synthesized by liver and biliary tract, and when the level of these enzymes in the blood increases, we can diagnose the disease of liver or biliary tract. We will study the enzymes one by one. The first enzyme is alanine aminotransferase. The another name of this enzyme is serum glutamate pyruvate transferase, SGPT. It requires coenzyme pyridoxal phosphate for its activity. Its normal range in the blood is 5 to 30 unit per liter, and it catalyzes the conversion of pyruvate and alpha ketoglutarate into glutamic acid and alanine. The level of ALT increases mainly in parenchymal liver diseases. It may be acute parenchymal liver disease or may be chronic parenchymal liver disease. In case of acute parenchymal liver diseases, the level of ALT may rises from 300 to 1000 unit per liter. And the causes of acute parenchymal liver diseases may be toxic or viral origin. Toxic means it may be either due to overdose of drugs or maybe because of poisons. And second thing is that the rise in ALT is seen much early. That means before the clinical signs of jaundice. All of us know that in liver diseases, the metabolism of bilirubin is hampered. Therefore, the level of bilirubin in the blood increases, which lead to jaundice. But the ALT level decreases much before the appearance of jaundice. That means it helps in the early diagnosis of parenchymal liver disease. Now, in case of chronic parenchymal liver diseases, the ALT level increases from 50 to 100 unit per liter, and the causes of chronic liver diseases are namely cirrhosis of liver, hepatitis C, you can add hepatitis B, non-alcoholic steatohepatitis, and etc. So ALT is very important enzyme in both acute as well as chronic parenchymal liver disease. Now the second enzyme is aspartate aminotransferase. It is also called as serum glutamate oxaloacetate transferase. It also requires coenzyme pyridoxal phosphate. Its normal range in the blood is 7 to 35 unit per liter. It catalyzes the conversion of aspartate and alpha ketoglutarate into glutamic acid and oxaloacetate. The blood level of AST enzyme also increases in parenchymal liver diseases, so it is also a marker of parenchymal liver disease. It shows moderate to drastic increase in liver diseases. It may be hepatitis or malignancies of liver. Now another enzyme is alkaline phosphatase. It is non-specific enzyme because it is synthesized by many tissues. It is called as ectoenzyme because it is not present inside the cell, but it is present inside the cell membrane, where it helps in the transport mechanisms. It is found in liver, kidney and intestinal mucosa. This point you have to remember while interpreting the results of alkaline phosphatase. It acts between the pH 9 to 10 and hence it is called as alkaline phosphatase. Alkaline phosphatase is activated by magnesium and manganese ions, and zinc is present in it as its constituent. Its normal range in the blood is from 40 to 125 unit per liter. Its level is also higher in children due to increased osteoblastic activities of the growing bones. Alkaline phosphatase catalyzes the reaction in which it removes the phosphate from any organic phosphate compound and makes this inorganic phosphate available for various reactions and deposition in bones. Moderate rise of alkaline phosphatase, about 2 to 3 times the normal, is seen in hepatic disease, infective hepatitis, alcoholic hepatitis or hepatocellular carcinoma. The level of alkaline phosphatase are increased to a very high level of about 10 to 12 times the normal in obstructive jaundice. So this alkaline phosphatase helps us to distinguish obstructive jaundice from other types of jaundice. This is because alkaline phosphatase is synthesized by the epithelial cells of biliary canaliculi or biliary tree. If there is obstruction to the flow of bile due to any reason, then the bile gets stagnant into the biliary tract, and that bile irritates the epithelial cells of biliary tract, and hence epithelial cell will synthesize more and more alkaline phosphatase in the blood. As I have already told you that the level of alkaline phosphatase is also affected in bone diseases. So when we are interpreting the results of alkaline phosphatase, at that time you have to remember this point. Another enzyme is nucleotide phosphatase, NTP. It is also known as 5' nucleotidase. It acts on 5' nucleotides at pH 7.5 and removes its phosphate bond and convert it into nucleotides. It is also an ectoenzyme and present in plasma membrane. Its normal range is 2 to 10 international unit per liter. It is moderately increased in hepatitis but highly increased in biliary obstruction. So this enzyme also used for the diagnosis of obstructive type of jaundice like alkaline phosphatase. But it differs from alkaline phosphatase in two ways. nickel ions inhibit NTP, but nickel ions does not inhibit alkaline phosphatase. And second thing is that NTP is not affected in bone diseases, just like alkaline phosphatase. The last enzyme in liver and biliary tract disease is gamma glutamyl transferase or GGT. Another name is glutamine transpeptidase. Now this enzyme catalyzes the reaction in which it removes gamma glutamyl group from glutathione. What is glutathione? Glutathione is a tripeptide made up of 3 amino acids, glutamic acid, cysteine and glycine. Here glutamic acid is named gamma glutamyl because at the gamma carbon of glutamic acid extra carboxyl group is present. Therefore the glutamic acid is also called as gamma glutamyl. So this enzyme GGT removes the gamma glutamyl amino acid from the glutathione and transfer it to the acceptor to form gamma glutamyl acceptor. Now this enzyme also catalyzes the reversal of this reaction in which it transfers the gamma glutamyl group from donor to cysteine glycine to resynthesize the glutathione. So the main use of this enzyme in the body is in the synthesis of glutathione. This GGT has 11 isoenzymes. It is also found in liver, kidneys, pancreas, intestinal mucosa and prostate glands. So this point you have to remember while interpreting the results of GGT. Its normal level is 10 to 30 units per liter. It is moderately increased in infective hepatitis, prostate cancers and alcohol abuse, means alcoholic patients. This GGT has clinical importance. The GGT level is increased in alcohols very early, even before the other liver parameters are in the normal range. So it increases early in the alcoholic patients. Its level also falls rapidly as soon as the person stops intake of alcohol. So this gamma GGT will helps us, or it tells us about the alcohol intake of the patient. Increase in GGT level is generally proportional to the amount of alcohol intake. So this GGT is important for diagnosis of alcohol abuse. Now the summary of liver and biliary tract disease. 4 enzymes are there. First is alkaline aminotransferase, which is a marker of parenchymal liver disease. Second is aspartate aminotransferase. It is also a marker of parenchymal liver disease. In clinical practice, for diagnosis of liver parenchymal disease, ALT is preferred over AST. Third enzyme is alkaline phosphatase, which helps in the diagnosis of obstructive jaundice or obstructive liver disease. Gamma glutamyl transferase helps in both obstructive jaundice as well as it has main role in alcohol liver disease or alcohol abuse. Now the next disease is pancreatic disease. 2 enzymes are generally studied for the diagnosis of pancreatic disease. These are amylase and lipase. Amylase is a marker of acute pancreatitis as well as inflammation of salivary glands, whereas lipase is the marker of only pancreatitis, so it is more specific as compared to amylase. Amylase, we will study amylase first. It is synthesized by pancreas and salivary glands. It catalyzes the conversion of starch into maltose. It is activated by ions like calcium and chlorides. Its normal value in the blood is 50 to 120 international unit per liter. It increases in acute pancreatitis on first day and remains elevated for 7 to 10 days. Sometimes in acute pancreatitis, the level of amylase may increase up to 1000 times the normal. Generally, the peak value of amylase is obtained between 5 to 12 hours of onset of disease, and the level of amylase in the blood returns to normal within 2 to 4 hours after the acute pancreatic phase subsides. Moderate increase in the amylase level is also seen in chronic pancreatitis, mumps, and obstruction of pancreatic duct. The normal level of amylase in urine is less than 375 unit per liter, but in case of acute pancreatitis, this level get increased. The second enzyme in pancreatic disease is lipase. The enzyme is present in pancreatic secretion which regurgitate back into the blood. Now this lipase acts on triglycerides and removes the two fatty acids from first and third carbon of glycerol molecule and convert the triglyceride into beta monoglycerides. The level of this enzyme in the blood is elevated in acute pancreatitis and it may persist for 7 to 14 days. Thus, lipase remains elevated longer than amylase. Moreover, the lipase is not increased in mumps. Therefore, it is more specific for pancreatic disease and has advantage over amylase. It is moderately increased in carcinoma of pancreas, biliary disease, and perforating ulcers. Now the next important disease is myocardial infarction. For the diagnosis of myocardial infarction in clinical practice, generally 4 markers are used, out of which 3 are enzymes, and the 4th marker, that is cardiac troponins, which is very specific, sensitive, and increase very early in myocardial infarction, is not an enzyme. But as it is used, I have mentioned here. Our topic is interpretation of serum enzymes. So in this topic we will see only first 3 enzymes and not cardiac troponins. So the first enzyme is creatine kinase MB. It is actually a isoenzyme of creatine kinase. It is specifically found in cardiac muscles. That means no other tissue will synthesize creatine kinase MB isoenzyme. So it helps in the diagnosis of myocardial infarction. It catalyzes the conversion of creatine into creatine phosphate by transferring a inorganic phosphate from ATP and convert the ATP into ADP. This slide shows the pattern how it increases. On the x-axis I have taken the time in hours and on y-axis I have taken the levels of CKMB. The levels of CKMB starts rise within 6 hours of myocardial infarction, reaches the peak value in 18 to 24 hours and comes to normal in 36 to 72 hours. If we plot a graph by taking the values of CKMB, then area under curve of initial rise is directly proportional to the size of myocardial infarct. That means if the level of CKMB is more, then we will get a peak of at high level, and the area which has come under the graph is proportional to the size of myocardial damage. Now after returning the normal level or after decreasing the level of CKMB, if again second peak is seen, that indicates another ischemic attack. So myocardial infarction The CKMB or CPKMB plays an important role in the diagnosis as well as to evaluate how much damage has occurred. CKMB is specific marker. It rises early in the myocardial infarction and no other tissue synthesizes the CKMB. CKMB level is not increased in hemolysis and in congestive cardiac failure, therefore it has advantage over LDH or other enzymes. The second enzyme is aspartate amino transferase. Another name is serum glutamate oxaloacetate transferase, SGOT, not PT. It catalyzes the conversion of aspartic acid and alpha ketoglutarate into oxaloacetate and glutamic acids. The normal level of AST is 77 to 35 unit per liter. The level of AST start rising within 24 to 36 hours of myocardial infarction, reaches the peak in 4 to 5 days and comes to normal in 10 to 12 days. So on the right side the graph shows the levels of AST. On the x-axis I have plotted time in days and y-axis indicates the level of AST. Lactate dehydrogenase, it catalyzes the conversion of pyruvate to lactate by adding 2 hydrogen atoms donated by reduced NADH. The normal level of LDH is 100 to 200 unit per liter. It has 4 subunits and these 4 subunits are of 2 different polypeptide chains. One is H chain, H stands for heart, and another is M chain, which stands for muscles. It forms 5 isoenzymes. The level of LDH start rising within 6 to 12 hours of myocardial infarction, achieves the peak value in 24 to 48 hours and comes to normal in 6 to 8 days. So again this graph shows the pattern of LDH in myocardial infarction. This is a combined graph showing CKMB level, LDH and SGOT. From this graph it is clear that CKMB is rising early as well as it is declining early in case of myocardial infarction, followed by LDH and SGOT. So as I have told you earlier, CKMB is early marker of myocardial infarction as well as it is specific for heart muscles. Another disease is skeletal muscle disease. The enzyme studied in skeletal muscle diseases are creatine kinase, aspartate amino transferase and aldolase. Creatine kinase level increases in muscle disease. Aspartate levels are also increases in muscle disease but not specific. Aldolase, though it is the earliest marker or early to rise in skeletal muscle disease, but it is not specific. First about creatine kinase. It catalyzes the conversion of creatine to creatine phosphate by removing inorganic phosphate from ATP. The normal range of creatine kinase is 15 to 100 unit per liter. Creatine kinase is a dimer made up of 2 subunits or polypeptide chains. These subunits are B stands for brain and M subunit which stands for muscles. Creatine kinase has 3 isoenzymes. Creatine kinase MM found in muscles and which contributes 80% of total creatine kinase. Second isoenzyme is creatine kinase MB found in heart muscle and it contributes 5% of total creatine kinase. Third isoenzyme is creatine kinase BB which is found in brain and it contributes about 1% of total creatine kinase. The level of creatine kinase in serum increases in muscular dystrophies, may reaches up to 100 to 115 international unit per liter. In female carriers of X-linked muscular dystrophy, heterozygous state, creatine kinase is moderately increased. Creatine kinase levels are also elevated in crush injuries, fracture and acute cerebrovascular accidents. The next enzyme which is studied in skeletal muscle disease is aspartate amino transferase. It is also called as serum glutamate oxaloacetate transferase. It requires coenzyme pyridoxal phosphate and its normal range is 7 to 35 unit per liter. It catalyzes the conversion of aspartate and alpha ketoglutarate into glutamic acid and oxaloacetate. Next enzyme is aldolase. It starts rising early in skeletal muscle disease, but it is not specific because it is synthesized by other tissues also. It catalyzes the conversion of fructose 1,6-bisphosphate into glyceraldehyde 3-phosphate and dihydroxyacetone phosphate. And the last disease is bone disease. The important enzyme in bone disease is alkaline phosphatase. Marked elevation of alkaline phosphatase is seen in rickets and Paget's disease. It is a type of cancer. Alkaline phosphatase catalyzes the reaction in which it removes a phosphate group from organic phosphate compound. The normal range of alkaline phosphatase is 40 to 125 unit per liter. Its level increases up to 20 to 25 times of normal in case of bone diseases. Again, while interpreting the results, we have to remember that growing bones also synthesizes alkaline phosphatase. So, the age of the children should be kept in mind while interpreting the results of alkaline phosphatase. So, this is about the interpretation of levels of various serum enzymes in different diseases. Thank you very much.